to thank my co-chair. We try a little bit to facilitate the session, Michael. Thank you very much.
Okay.
Thank you very much.
Bye.
Bye,
Bye-bye.
Sophia. Bye.
Bye.
Thank you.
So we have an excellent next session about how to use CMR to perform basic and advanced evaluation of the heart.
All right, thanks for this introduction. My name is Dr. Guus de Waard. I work at the Radboud University Medical Center in Nijmegen, the Netherlands. And we will perform a session together with my, well, not colleague, but Marieke Vermeulen. She works as an application specialist for Medis, a software company. And what we'll be discussing in the next half an hour probably is going to be on how to acquire and interpret CMR strain, but also we will show you the basics of how to perform quantifications of the left ventricular volumes and the right ventricular volumes. And this session is going to be a little bit different because typically, of course, we would just give talk and overviews and, well, that's it. But this is going to be more practical. So what we'll do is Marieke will first give you a short introduction of a couple of minutes on the Medis software. And then I'll take over and I'll discuss a bit about how to perform the quantifications of left and right ventricular volumes and ejection fractions, discuss the theoretical basis of ventricular and atrial strain. And then what we'll do is we'll follow it up with a few cases and show you live how to perform these measurements with the new automated Medis software. Which is also available for a trial period if you ask Medis for it. So that's very nice, and I would recommend trying that out. So to start off, I'll give the word to Marieke, who will kick off.
Yeah, thank you, Guus, for the introduction. So to kick off this presentation, I'll just want to give a brief introduction into Medis Medical Imaging. So Medis Medical Imaging is a post-processing company where we post-process cardiovascular images, and we do that multimodality. But for today, we want to focus, of course, on our CMR product, which is a comprehensive, time-saving, and validated solution for cardiac MR post-processing. Within this software, we provide a full suite, so we can evaluate anatomy, heart function, flow analysis, and tissue characterization. We do this in various modules, which are available in different combination based on the clinical needs of our customers. The software is very accurate. We stem up from the Leiden University Medical Center, and we were really pioneers in CMR post-processing. This leaves us trusted globally, and we're supported by more than 1,500 studies. In the recent years, we put a lot of effort in AI-driven efficiency. We try to automate as much as possible of the workflow by deploying our AI algorithms. On top of that, we try to be innovative all the time. And right now, we do this with our innovative parameters, which is, of course, strain, but we go even beyond the strain. So the next step already, which is hemodynamic forces, inward displacement, and non-invasive PV loops. And all these parameters are exclusive to Medis MR. And all of this is available, like I said, in one platform, in one product, which can be well integrated into your hospital environment. So here, just a quick overview. I will not go into detail into all of these modules, but just to give you an overview of all the modules that you can process with the Medis MR software. So as you can see, it's quite an extensive tool set. So overall, with Medis MR, we want to simplify your clinical workflow. And we do this by having a image acquisition and visualization tool where you can easily view and review your images. Then afterwards, you can analyze these images to perform quantitative assessment, and all your assessments are then gathered in one clinical report, which can be exported to, for example, your PACS. So this will be a very brief introduction, and like Guus already said, you can trial it at the end of the presentation. We have a QR code which you could scan, and then I want to give the floor back to Guus to provide an introduction in strain.
Yeah, so I've also discussed briefly the quantitative LV assessment, which you obviously acquire on the short axis CNS stack that you typically acquire. What can be said about this is that for the left ventricular and diastolic images, it is necessary to choose the image with the largest LV blood volume. And for the LV and systolic images, you should pick the one with the smallest LV blood volume. What is then important is that the papillary muscles and its orbiculi can either be or not be included into the analysis that you will take. I think what is recommended was to include the papillary muscles and tuberculi, but yeah, of course, it's a little bit easier not to include them. So in clinical practice, at least in my institution, for clinical purposes, we do not include them in our analysis. Whatever you choose, it's important to be consistent, of course, for the systolic and diastolic images. And of course, it's also important to take into account that the reference values will change a little bit depending on whether or not you will include the PAP muscles or not. What is then important is that the LV outflow tract is in fact included as part of the left ventricular blood volume, and to make sure that the contours are approximating the aortic valve for the left ventricle, and of course for the pulmonary valve for the right ventricle. Then for the basal slice, it's important to know that this obviously changes a little bit during systole and diastole. So in diastole, the basal slice is typically 1 or 2 slices above the systolic slice, and to select these slices, it's important that at least 50% of the blood volume is surrounded by myocardium. And again, during systole, the basal slice can be located a little bit more apically. Next. So this is obviously reported in this 2020 overview paper, and here you can see an example where you see on the left side of your screen, you'll see the diastolic images, and on the right side of the screen, you'll see the systolic images. And what you can appreciate is that the basal slice is again located a little bit more apically. You can see again that the LVOT is included here. And in this example, I think they did include the papillary muscles, if I'm correct. Okay, next slide. Then moving on to the strain analysis, this is actually quite interesting. And as you'll see in the cases later on, there are some clinical applications that we're beginning to explore. And I think we do not routinely use it a lot in clinical practice, but especially for some cases, we're trying to incorporate it a little bit more in our reports as well. Also for a clinical perspective, especially in those patients who have, for example, a genetic mutation, but their ejection fraction is still normal, or patients who underwent chemotherapy with cardiotoxicity potentially. These strain images can be helpful to detect early myocardial damage. What's important to realize is that the myocardial fibers are actually orientated in such a way that the myocardium gets this twisting contraction, where there's superficial longitudinal fibers, there are inner horizontal fibers, inner longitudinal fibers, and that's leading to that nice twisting motion that you can really, I think, better even appreciate with CMR than you can typically see it with echo. Next slide. So these myocardial fibers, they have the orientation, as I was discussing, where the longitudinal fibers are more in the endocardium, then the horizontal fibers in midwall, and then in the epicardium, the other fibers, and then this will lead to 3 different types of shortening that you could separately assess with strain. So there's the longitudinal shortening, then there's the radial shortening, and then there's also the circumferential shortening, and all of these 3 different types also have their respective strains. Next slide. So this is for the strain analysis, and as you can appreciate here, you can perform the strain analysis with CMR, but it's also, of course, possible, as you've probably done in clinical practice, to do it with 2D echo or with 3D echo. And really, what's an advantage, I think, of CMR? We'd use the endocardial global longitudinal strain, typically tracking the endocardial borders, is that it has a very high signal-to-noise ratio, which has been reported to be higher, at least for CMR, than for the echo modalities. That the reproducibility is high, but it's important to take into account that there are intervendor differences. So that is an important factor. Again, for clinical practice, we typically use the endocardial global longitudinal strain. Next slide. So this is a nice overview of a meta-analysis to assess all the different strain values that have been reported. And it's good to know that for the endocardial global longitudinal strain, we arrive at a reference value of approximately -23. And as you'll know, lower values of strain are obviously suggesting that there is a problem. So higher negative values are better. Then you can also assess strain for the atria. We do not at this point use that routinely in clinical practice, and it's typically, I think, reserved for scientific purposes. But as we'll go further, it might be something that enters the clinical space as well. And for the left atrial strain, there are also reported reference values that you can see here, 24 and 20% for the conduit or passive strain, and the booster or active strain. And the booster active strain is, of course, the atrial contraction, and the conduit or passive strain is just a passive filling of the left atrium. Next slide. So there are a couple of things that are important for acquisition in terms of strain analysis. So for high quality strain analysis, you need perfectly acquired long axis cine images, which go through the mid mitral valve annulus and straight through the apex. It's important that there is a high temporal resolution. This is, of course, the advantage of CMR. So 30 frames per cardiac cycle are recommended. And what is very important is that in your protocol, when you acquire the strain analysis, that you do it before you give contrast, because that will mess with the strain values. Next slide. So you can really, in terms of the global longitudinal strain values can be obtained for the different segments. And as I said, for clinical purposes, we use the endocardial GLS. Next slide. Then here you see an overview of the left atrial strain, which hasn't really entered the clinical space in our center yet. So there's different components that we can appreciate for the left atrial strain. Again, the conduit and the booster strain, and that represents, again, which you can see in the bottom, the passive filling and the atrial kick. And you can separately or assess them together. Next slide. So you can appreciate multiple different left atrial strain patterns. Normally, there's, of course, a high left atrial strain with both a good passive filling and a good atrial kick represented in the normal case, with sort of advanced stages of HCM. Of course, when there's only a little bit of HCM, it will be less, but especially in advanced stages, there's also atrial myopathy. So you'll see that the total strain is reduced, and that both the passive and the booster strain will be reduced there. In DCM, again, there's also a reduced strain. And in ischemic cardiomyopathy, we also see that there's a reduced atrial strain. Next slide, please. So now what we'll do is we'll show a couple of cases where Marika will use the MEDIS software to demonstrate how the analysis are done, both of the left and right ventricular volumes, but also of the strain values. And we'll just start off with a normal case to show how it normally looks, and Marika will guide you through how that looks. This is a CMR acquired in a 22-year-old with no symptoms, and when we did the analysis, we arrived at very good values. So Marika, please take over.
Yes, I am going to switch my screen sharing so that you guys now see the MetaSuite MR software. So right now we are in the patient browser where you have a list of all your patients. And as Guus was describing, Dr. De Waard, we're now going to first do a normal case. And to start the analysis, I'm going to just click on the Launch Analysis button. What the software will now be doing is it will be loading all the different data sets which are in this patient. And the software is going to go through all these data sets, and it's going to classify them, and it's going to automatically detect your cine images. And these are the images that you require for the volumetric and strain analysis that Dr. De Waard has been introducing. And that is also what we can already see here in this viewport. The short axis stack here in the top row has been automatically detected by the software. And at the middle row, we do see here the 2-chamber, the 3-chamber, and the 4-chamber are automatically detected and loaded by the software. On top of that, I would like to explain you that MEDIS uses something which is called AutoQ. AutoQ is an AI algorithm that can run in the background. So as soon as the images arrive at MEDIS, MEDIS will already analyze AutoQ, and AutoQ will detect the myocardial contours. So this entails both the endocardium contour and the epicardial contour, so that whenever you load the data, you will be able to automatically have those contours. Of course, you can review them, you can correct them, but this really speeds up your workflow in quantifying volume and strain. So now let's have a look here in QMAS. QMAS is our module where you can perform functional assessment. So here we do see that indeed the endocardium and epicardium border of the LV is detected and the endocardium border of the RV. For the volumetric assessment, the detection of systole and diastole is of course of importance. So here we can see that the software automatically detected systole and also here diastole. Then when we go into the functional analysis step, here we will have an overview of the fully automated quantification of the ventricle, but of course always review and correct where necessary. Guus, is there already something you want to comment on these numbers?
No, well, I think these numbers all look normal to me. So yeah, what I want to highlight, and that may be something that older cardiologists, and even at the beginning of my fellowship 2.5 years ago or 2 years ago, I had the same thing when we still needed to segment all these contours, and it was a tedious, long process. And yeah, with these new advances, I think for MEDIS, but also probably for the other vendors are working on the same thing, that really speeds up the process and makes it more feasible for the post-processing part. And it will really make a big difference, I think, in clinical practice when using AI, which is integrated into this software already. I think it will make a tremendous difference in applicability. Still, you have to do the qualitative assessment yourself at this point. In the future, maybe that will also change, but at least the quantitative part, the software can help you a lot. So I think we can go to the next case that we have lined up. Now we're gonna show some pathology. Or you want to show the strain first? Sorry.
Yeah, maybe briefly indeed, besides the volume assessment, Dr. De Waard was also talking about strain, and I would just like to highlight that as we can see over here, is also something that MEDIS does provide automatically.
Yep, and you can really see that all the different GLS, GCS, and yeah, you get all these values. You get the atrial strain, or you have to specifically do that, I think, right? The atrial strain. You don't get it automatically. Okay.
It is. You can have it automated, but you just have to switch the mode from left ventricle to left atrium.
Okay.
And maybe
let's
here
go to,
is that, just to highlight here, is that the endo-GLS parameter that you mentioned was the most important in clinical practice.
Yep. Okay, now we'll go to some pathology. So it will get a little bit more interesting, I think. So I think this is a beautiful scan that you will see, and we can go through as well. This is a 55-year-old male. He has a prior CVA, and the echo, there was an echo done in the workup for, because he had this CVA, to see if there was a cardiac cause of the thromboembolism, and it revealed already sparkling myocardium. There was a mildly reduced EF, and already together with the microvoltages that were seen on the ECG, there was, of course, a high suspicion of amyloidosis. And you can see that here as well. I just want to briefly, before we enter the quantifications, I'll briefly want to discuss with you the images that you can see on the right side of your screen. You can see that it's very difficult to null this myocardium in the LGE images, which are very faint. But if you look carefully, you can already see that there's LGE as well. There's pericardial effusion that you can already see. And on the images on the left, you can also already appreciate pleural effusion. What's also remarkable is that the T1 times are extremely elevated, which we use a 1.5 Tesla scanner. So the cutoff values do differ, of course, between 1.5 and 3 Tesla. But with our 1.5 Tesla scanner, we found T1 times globally of more than 1100 milliseconds. So that's highly elevated. It's very suspective of amyloid disease, of course, with a very large extracellular volume of 60%. Yeah, Marika, you can run the analysis now and show us that.
Yeah, so just opening up case 106, which corresponds to the case that Dr. De Waard has just been introducing. So while we're opening up the case, again, we will see that QMAS and QStrain will open. So first, we'll open up the QMAS instance, so we can have a look and discuss the volumetric assessment of this patient. Yes. So here again, we can see here the data. Maybe I can quickly play a movie where we can see the different images over time, including all the contours. I can also show it in this fashion, so we can appreciate all the contours that have been automatically processed by MEDIS. Now let's have a look into the actual quantification.
Yep, so we'll notice that the LV is quite severely reduced, a moderate systolic dysfunction with an LVEF of 37 at this point. The mass is increased, of course, as you will get concentric hypertrophy due to all the amyloid depositions that go in through the not myocardial hypertrophy, but you'll get so you get the amyloid depositions, which will cause the LV mass to be increased. Obviously, the amyloidosis is not restricted to the left ventricle, so even the right ventricle will be reduced with right ventricular hypertrophy as well. And I think it will also be very interesting to show the strain values for this case. And you'll get that here. And what you can appreciate is even when you take into account echo, you typically have the cherry on top appearance where there is apical sparing of the strain values, where the strain values in the apex are still relatively preserved. Whereas in the rest of the left ventricle, they will be severely reduced. And that is also a pattern that you will see emerging here as well, where especially when you look at the bullseye plot, you'll see that the endocardial GLS will be much closer to the zero for the basal slice, whereas when you move into the apex, into more of the bullseye, you'll see that the strain is higher there. So that's really useful as well, I think. I mean, you already have the diagnosis, of course. It's just an extra bit. Right. So I think we can move on to the next case then.
Yes. I'll close this one and I'll switch the screens again.
So this case, I think, highlights where we really do, where strain analysis really does have an additive value, because, of course, in the amyloidosis case, well, you already had the diagnosis, but for this case, a 35-year-old male who had a nephroblastoma, and he received chemotherapy with a cardiotoxic agent. Had radiotherapy as well, underwent nephrectomy. Now he had a little bit of a reduced ejection fraction on echo, but when we did the CMR analysis, I'm not sure which values we'll get this time, but it was very close to the cutoff value of 53, which is right about where you would say, is this mildly reduced or is this still normal? In this case, T1 times were actually still preserved, 110. So you'll quite often see in cardiotoxicity that the T1 times are elevated as a marker of diffuse interstitial fibrosis. But in this case, the T1 times were still within normal range. You'll see on the right side of the screen that there was no late gadolinium enhancement in this case. And I think, again, we can go back to the analysis to show what we get. I haven't run the METIS analysis for this specific case, so let's see what the automated analysis says, if it's still a normal ejection fraction or whether it's mildly reduced.
Yeah, I also don't remember from the top of my head what was the number here, so that's going to be an exciting case. Yeah, and indeed, good to mention this. What I'm loading up right now, it's all with the outer queue, so it doesn't have the an expert review over it yet. So let's see how the numbers differ, but that could, of course, be a difference.
And of course, it's really important to remember that when you do this analysis at this point, I think still we really have to check them ourselves to see if it fits with all the prescribed recommendations for the LV and RV analysis. But yeah, it's obviously much easier if you only have to do a slight correction of the contours, or whether you have to draw them all yourself. So yeah, it's an advantage. So here it is actually a little bit reduced, right? LVEF of 45.
Yeah, here it's 45 indeed, LVEF.
Yeah. So I'll have to check whether that's it agrees more with the echo than the score that we had. So let's go to the strain analysis and show how that is. So here we actually arrive at an endo GLS of 17. And if taken all together, that is, of course, reduced, because slightly reduced, of course. The echo cutoff value is what we typically use in clinical practice is minus 18.5. And as you saw in the slides that I showed, is that the normal value is approximately 22 for CMR. So it is mildly reduced strain. Then for the LVEF, we really have to, we should really check the contours and see whether or not the LVEF would fall into a normal value or not. Do we still have time for the final case? I don't know.
Yeah, and maybe here we also have this one, Dr. Waard. So here we also have an atrial strain analysis. So with METIS, you can load both the 2-chamber and the 4-chamber so that you can perform a biplane analysis of the left atrium. And as you can see here, also different phases are indicated. So ventricular end systole and ventricular end diastole. And indeed kind of this start of the A wave, which is basically where we define the difference between the shift between the atrial kick and the active filling. So here in the software, you can click also on this information icon. Also that contractile phase, that Condry phase, and that reservoir phase are reported by the software.
Yep, beautiful. Okay, let's briefly do the last case. I'll go over it quickly because we are running out of time, I think.
So let me briefly go back to the slides. Final case.
Because I didn't want to withhold this case for you. It's 21 years old male who has a myosin binding protein C3 gene mutation with HCM. He underwent a Moreau myectomy when he was 10 years old. Now on echo, he did not have residual LVOT obstruction after exercise and Valsalva, of course. But he has quite a few symptoms. He has angina, palpitations with non-sustained VT. You'll see obviously a very thickened myocardium with asymmetric hypertrophy, especially at the septum, even after he underwent that Moreau procedure. You'll see at the late gadolinium enhancement that there's extensive patchy late gadolinium enhancement. And what's also nice is that you can, I think, you might be able to. No, I'm unsure about that. But yeah, this is, of course, a very severe case, and it's remarkable that his brother was a couple of years older. Yeah, you wouldn't be able to tell the difference of the CMRs if you compared them, because he had exactly the same appearance. Also, when Moreau, he already had an ICD. You can see in this case the patient does not have an ICD yet. He received it after we had this MRI and we worked out the ventricular arrhythmia sudden cardiac death score, which was elevated. He received an ICD. Unfortunately, it had to be a transvenous ICD. Couldn't fit in subcutaneous because of the vectors that didn't match up. So yeah, we'll show the case now, the analysis. And we tried this case and we already saw that the software ran into a little bit of problems in this case. So that highlights the importance that you also have to look yourself.
Yeah, so our AIs are trained on large databases, including healthy cases, pathology cases, different types of pathologies. But indeed, when we have very severe pathology, you'll see that AIs are. It's never a question if an AI will fail. An AI will, in any cases, at some point fail. So this is indeed a very interesting case to show. Did I open
it looks quite normal when I see them flashing.
Yeah.
Is it not the right one, or?
Wait, it was case 105. Let me open.
Yeah.
I think this might still be the previous one that we were discussing.
Right. Yeah.
This one should be the right one. Sorry for that. Yes, there it goes. Yes, this looks more like the images we just saw on the slides. Okay, so again, let's first, after the loading, go back to our QMAS software, where we can see the short axis stack and the auto-generated contours. Yes. So maybe just to get a bit of an idea of all the contours, let us pull up this one. So here we can see indeed here, especially basally, both for the LV and the RV, that the software is struggling, especially at end systole, since it's quite challenging for the AI to differentiate between what is trabeculation, what is still myocardium. So let me close this one and just go through an example. For example, here, at Medis, we have several tools in which you can manually correct. So the most easy one is just to bend the contours into the proper direction. And it's good to mention, as soon as you do some manual edits, you can see that over here as well, that we've edited something, and all your manual edits are automatically taken into account into the quantifications as well.
Very thickened moderator band as well, right? On the screen that you're pulling up now, that's giving it a little bit of problems as well, I think, in the right ventricle. Yep.
Yeah, definitely. And also here we can appreciate the strain, and here it was, this one is endocardium only. And there it performs still pretty okay, but as soon as you're going to include the epicardium, because the epicardium is so thick, this could pose some challenges.
Yeah, and here I just wanted to highlight the bullseye plot, right, where you can really appreciate that in the septum, the anteroseptum in particular, is of course where the hypertrophy is and where the Moreau procedure took place. You can really see when you look segmented that the strain values are very abnormal, whereas in some of the other spots, especially apically and infralaterally, the strain values are still relatively preserved. So really highlights the disease nicely, I think, here. Okay, I think that's all for us. Please take a picture of this this slide if you want to try the Medis suite out. We'll leave that up. You can just use the QR code to find that and ask for a trial period. That's maybe a nice thing to do.
And it's very easy. You'll have a cloud access, so no need to install anything on your laptops. You can just you'll just get a password and a username, and you can access immediately for 2 weeks.
Okay, thanks.
Thank you so much. I have to tell you that you succeeded the impossible to make simple and clear the most difficult problems of cardiology using imaging. This is due to your scientific experience and, of course, to excellent softwares you use. And we really enjoyed so much because this is the most important thing, make the difficult easy. Thanks a lot. I'm very, very grateful to both of you.
Thank you so much.
Thank you very much.
It was an honor to be invited.
Join us next year too. It was
Definitely
very helpful.
It would be a
great pleasure to have you with us.
Thank you so much, and a pleasure to be here. And good luck to all the audience with the rest of the course.
Okay. Thank you. Thank
Bye-bye.
you so much. Bye-bye.
Thank you all. Bye-bye.